After getting appropriate history for the patient, I will perform hand hygiene, introduce myself to the patient, identify the patient with two identifiers, the name and date of birth, provide adequate privacy. My assessment will start with inspection, palpation, and auscultation for the cardiovascular system. For inspection, I will look for the patient's skin color, fingernails, toenails, for any color changes. If the fingernail is pink, pale, or dusky, if there is any clubbing. I will compare right hand with left hand. I will also look for the cap refill, which is less than 2 seconds for this patient. I will look for any hair distribution in the arm, legs, or in the chest wall. Any venous pattern for which I can use a pen light. I will look for atrophy of the muscle in the hand, or also look for edema in the hand or in the ankle or feet. After inspecting these areas, I will look for the jugular vein pressure in the right neck. To obtain the jugular vein pressure, which indicates the right heart pressure, I will put my patient in a supine position with head of the bed elevated 45 degrees. I will use a white cardboard paper, which is hard enough, and also a ruler. I will try to identify the external jugular vein in both sides, right and left, and compare both. Then I will identify the oscillation point of the right internal jugular vein. Then I will hold this paper horizontal to the internal jugular vein oscillation point and use the ruler vertically from the sternal angle. The point where the white card meets at 90 degrees with the scale, which is 2 centimeters here, defines the jugular vein pressure, which is normal for this patient. If the jugular vein pressure is more than 3 to 4 from the sternal angle and 8 to 9 from the right atrium, that's considered increased jugular vein pressure. After inspecting jugular vein pressure, I will inspect the patient's chest wall. I will look for pulsation or any heaves. After inspecting these criteria, I will go for palpation. I will palpate for the skin temperature in the arms and in the legs with the dorsum of the hand, and then I will palpate for any thrills, heaves, or PMI. For that, I will use my finger pads at different points in the chest. Second intercostal space, right sternal border is the aortic area. Second intercostal, left sternal border is the pulmonic area. Third and fourth intercostal space, left sternal border is the tricuspid area, also known as right ventricular area. Fourth and fifth intercostal space with the mid-clavicular line is the apex of the heart. In these areas, I use my finger pad to look for thrills. I will use my hand pad to palpate these areas to look for heaves. The PMI is located 2.5 centimeter lateral to the apex of the heart, which I can palpate in this patient. If it's more than that, it should be abnormal. After palpating these areas, I will palpate for the pulses at different locations. For example, the carotid artery, and compare with the other side. The brachial artery, the radial artery, the ulnar artery, femoral artery, popliteal artery, dorsalis pedis, and posterior tibial. At the same time, I will compare the left with the right. I will look for the quality of the pulse and the quantity. +2 is the normal pulse. After palpating all these pulses, I will auscultate my patient's lungs at the different location of the chest wall. I will start with the diaphragm of the stethoscope at the aortic area, pulmonic area, third and fourth intercostal space, left sternal border, and the apex of the heart. The apex of the heart has prominent S1 sound, and S2 sound is prominent at the base of the heart, which are normal for this patient. At the same time, I will use the bell of the stethoscope to listen for any S3 and S4 sounds which are abnormal or any murmur. In this case, my patient doesn't have any S3 and S4 and any murmur. If the patient would have any murmur, I will look for the timing, location, and radiation. And also for S3 and S4, I will listen for the timing and intensity. Now, using the bell of my stethoscope, I will listen for any bruit in the carotid artery and compare with the other side. In this case, my patient is negative for bruit. I will use the bell of my stethoscope to listen for any pulmonic splitting of S2. While doing that, I'll tell my patient to inhale and exhale. After completing my auscultation, I will put my patient on the left lateral position and listen for the heart sounds at different locations again, which will help me to identify the S2, S3, and also the murmur. The aortic area, the pulmonic area, the right ventricular area, and the apex of the heart, which are negative for S3 and S4 and also murmur. This completes my cardiovascular assessment.